Hey guys, welcome back to my channel. Today I'm starting to read Psychiatry from 2025 version. Today we will read about mood stabilizers. So let's get started. So for mood stabilizers, we have to remember four names: lithium, divalproex, lamotrigine, and carbamazepine. Used mainly for long-term stabilization of bipolar disorder, also used as first-line monotherapy or in conjunction with atypical antipsychotics for acute episode of bipolar disorder. Example, depression and mania. So we have to remember the four names, which are those: lithium, divalproex, lamotrigine and carbamazepine. So the indication where we are using these drugs: used as first line monotherapy or in conjunction with, we are adding with atypical antipsychotics for acute episode of bipolar disorder, depression and mania. Vary in their ability to treat, reduce symptom acutely or stabilize, prevent relapse and recurrence, manic and depressive symptoms. Multi-agent therapy can be avoided in many patients, but it is common. Before initiating, get baseline CBC with differential and platelets. ECG. If the patient is more than 45 years old or cardiovascular risk. BUN, creatinine, electrolytes, TSH, LFT for divalproex and carbamazepine. And screen for pregnancy, thyroid, neurological, renal, liver, cardiovascular disease. Full effect may take 2 to 4 weeks, thus may need acute coverage with benzodiazepine or antipsychotics. So if one patient is coming with acute agitation, first we are giving benzodiazepines to calm the patient. Now specific prescribing information. It's not that much important. These 2, 3, 4 lines we can directly jump into the commonly used mood stabilizers. First is lithium. Lithium indication: first line acute mania, monotherapy or with adjunct second generation antipsychotic. Bipolar 1 depression, bipolar 2 depression. Dosage, we have to remember that adults can use 600 to 1500 milligram per day, but geriatric patient we have to give less, 150 to 600 microgram per day. We have to also remember the lithium's therapeutic level. For adults, 0.8 to 1 millimole per liter, and for geriatric patient 0.6 to 0.8 millimole per liter. Okay, so we have to monitor the lithium level because lithium can be very toxic. So monitor serum level every 5 to 7 days until the therapeutic level reaches. Therapeutic level is for adult, we just read 0.8 to 1 millimole per liter for adult. Always 12 after the dose. So think about that you gave the lithium dose at 8 p.m. So we have to take the blood level at 8 a.m. in the morning. So we are giving 12-hour time. Then monitor monthly, then 2 to 3 months. Also monitor thyroid function, creatinine every 6 months. So see blood level for the lithium, also monitor thyroid function and creatinine. So lithium side effects are very important for the exam. We have to remember most of the things here: diarrhea, nausea, vomiting, stomach pain, polyuria, polydipsia, nephrogenic diabetes insipidus. It's very important. Nephrogenic diabetes insipidus, glomerulonephritis, renal failure, decreased GFR, fine tremor, headache, fatigue, lethargy, hematologic, reversible benign leukocytosis. The most important is it's very teratogenic. It causes Epstein anomaly, fetal hypothyroidism, and worsening of psoriasis. So this drug causes worsening of psoriasis. So we cannot give in psoriasis patient the drug lithium. Also the interactions we have to remember. What drug are causing interactions? NSAIDs, thiazide, ACE inhibitor, metronidazole. Okay, that's for the lithium. First, we have to remember the indication where we are giving the lithium. Then you have to remember the therapeutic level. Then when we are monitoring, then the side effects and the drug interactions. Now we are reading about lamotrigine, also found here in Lamictal. The indication, first line indication is bipolar 1 depression and bipolar 2. Here we have to remember about the skin rash and suicidality when initiating the treatment. So we have to monitor the skin rash for lamotrigine, because here the risk of Stevenson-Johnson syndrome, it's very rare but it's an emergency. So we have to remember about the rash and suicidal thoughts of the patient. Lamotrigine is the best base drug in pregnancy. So if they say what is the best drug to give in pregnancy, mood stabilizer, choose lamotrigine first. Now we are reading about divalproex. So divalproex indications are acute mania, bipolar 1 depression, bipolar 2 depression. We don't have to remember the doses actually, but monitoring. We need to monitor what? Liver function test. Weekly, then 1 monthly. Then 2 to 3 months. Because divalproex causes liver dysfunction. So we have to check for the signs of liver dysfunction. What are those? Nausea, edema, malaise. And check platelet and monitor levels to adjust doses and confirm adherence. We have to ask the patient that are you taking the medication? Also we have to check the platelets and monitor the levels to adjust the dose. Okay, so for divalproex we have to know the side effects. What are those? Mostly we have to remember the most important. It causes thrombocytopenia and neural tube defect. Mostly we have to remember the neural tube defect, because if we give divalproex in pregnancy, it can cause neural tube defect. And it has one drug interaction. It has interaction with OCP. So we have to be very careful before giving divalproex. We have to tell the patient that you may need to double the OCP, or we can give double protection like 1 OCP plus 1 barrier method. Then we are reading carbamazepine. It's a second line for acute mania as a monotherapy. And here also we are monitoring the serum level every 5 to 7 days until the therapeutic level comes. Weekly blood count for first 1 month due to the risk of agranulocytosis. We have to remember this side effect. Carbamazepine causes agranulocytosis. It is rare, but it's emergency, so we have to remember. The side effect is agranulocytosis for carbamazepine. Now the side effect of carbamazepine. Side effects are diarrhea, hepatic toxicity, ataxia, dizziness, slurred speech, drowsiness, confusion, nystagmus, diplopia. Hematologic causes: transient leukopenia, rare agranulocytosis, aplastic anemia, rash. We have to remember here rash because here also Stevenson-Johnson syndrome and also agranulocytosis. Also it causes neural tube defect. So mostly neural tube defect problem is with two drugs here, divalproex and carbamazepine. OCP interaction, drug interaction, two drugs, divalproex and carbamazepine. So it was about mood stabilizer. Hope you all liked my video.